Hey, everybody. I am very excited for this conversation. We are speaking with Dr. Joseph Pinzone, who is the medical director at the Hyperthermia Cancer Institute in Santa Monica, California. We actually got to know Dr. Pinzone through Rachel, my wife. We spent 3 months in Santa Monica receiving hyperthermia treatment for Rachel, and have stayed connected with the Institute, Matt and Caitlin, and obviously Joseph. And so we're excited to have a conversation today about the science of heat and cancer, and really just dive into the facts of what is happening behind the scenes when you apply heat in a cancer situation. Perfect. So let's dive in because we're going to have a few different conversations that'll be over the next few weeks. But first, I really wanted to get into the science and geek out, because I know this is a passion of yours.
Yes.
So what is happening when you apply heat to cancer?
Okay. Well, let me give people a little bit of the history that goes with what we're doing. If you wanted to start, a reasonable place to start is something in, let's say, the 18th century, when people would get smallpox. Because in that particular disease, not that there was anything special about that disease in particular, seemingly, but you would have long febrile periods. And you'd also have an infection, so you'd have an immune reaction. And a very, very small percentage of patients with solid tumors, it was noted, would have partial or complete remission. So they would shrink totally or partially for a short amount of time or for permanently. And those were obviously ones that you could notice, let's say breast cancer as an example, where you could see it. So the connection between heat and immune reaction was surmised based upon what people noticed. Fast forward to the 1890s, and in New York, a doctor called William Coley noticed that a patient with sarcoma, a particular type of cancer, had a remission when she was diagnosed with erysipelas, which is caused by streptococcus. So again, a febrile illness. And so he started to inject these tumors with streptococcus, eventually just used the toxin as opposed to truly infecting somebody, which was a bit more dangerous, and combined it with another toxin from another bacteria. And his response rate was about 50%. We still have the William B. Coley Award. That was the first cancer vaccine. And so
wow, interesting.
Reasonable results in other types of tumors as well, but better in sarcoma than carcinoma, which carcinoma is the more common type of solid tumor.
Right.
Fast forward to the latter part of the last century, and we realized that heat in and of itself can do a lot, even in the absence of an infectious agent or a toxin from that infectious agent. The reason why is because, exactly as we're going to discuss, the science behind it was evaluated, and then this was developed into a particular device and a particular treatment modality. So when it was realized that you can heat a tumor to, let's say, 106 to 109 degrees, seems to be a sweet spot. People obviously have experimented with different levels of heating, but that seems to be a sweet spot. When you do that, what ends up happening is, because tumors are abnormal, they form blood vessels that are poorly formed, and they collapse at the center of the tumor. And you might think, oh, well, the cells at the center of the tumor, then they can't really live, right? They evolve to live in a low oxygen environment. So when you heat the tumor, you increase that blood flow. And so our modality, which I'll talk about in a second, is FDA approved to be used in conjunction with chemotherapy or radiation therapy. The reason why is because when you increase the blood flow, you now have delivery of that systemic agent. And in the past, it was just chemotherapy. These days, it's chemotherapy, it's targeted therapy, it's a variety of therapies. to the center of the tumor where it really didn't have access without heating. And so you see now increased complete response rates. That's typically what's looked at in the literature. And in some tumors, you actually get increased survival. Similarly, when you are receiving radiation therapy, heating brings blood, and with blood comes oxygen. And it just so happens that radiosensitizes. That is, it makes the tumor sensitive to the effect of radiation, because radiation takes the oxygen and it uses it to react with the DNA in the tumor to damage the DNA. So when the tumor goes to divide, if that DNA is damaged, it says can't divide, A. B, it sets off what's called apoptosis, or programmed cell death, and that's the mechanism of action. And frankly, that's also the mechanism of action of some types of chemotherapy. Interestingly, so as we further explain the science behind this, your body, cancer is this very, very, very interesting entity from a scientific perspective. I mean, it's horrendous clinically, of course, but to look at it from a scientific perspective, it's part of you, but yet it could be recognized as foreign, right? So we'll talk about the immune reaction in a second, but getting back to the DNA for a minute, it being part of you, your body actually has these compensatory mechanisms and says, we know how to repair DNA, we'll just repair the DNA. So heat can actually slow that enzymatic repair of the DNA. So that's mechanism number 2. And the final mechanism is when you heat something, it is analogous to giving that part of the body a fever. And I say that part of the body because we're part of the puzzle. As you well know, and we're now explaining to your audience, it's a local therapy. So we have an applicator head that goes directly onto the patient's, onto some plastic that covers some gel. But the point is there's contact of a cooled water bolus onto the skin. And when you do that, you deliver the heat deep into the body, which you really can't do in any other way. Even a sunburn doesn't go very deep. But getting back to what happens when you get a fever, or when you give that part of your body a super fever, you set off some things that are, not everything is appropriately named in medicine, but you set off something called heat shock protein 90. And what that does is it sets off a chain of other molecular reactions that ultimately result in dendritic cells. They're a part of the immune system that are responsible for presenting either infectious agents or abnormal proteins. And in this case, all of the proteins that are inside of that cancer cell, and some of them that are on the outside for that matter, the inside portion of them are released with the chemotherapy or with the radiation therapy. Now, that dendritic cell can take the mutated protein, which is, now that it's in the immune cascade, we reterm it a neoantigen. So meaning it's looked at as foreign. And so it takes that and it presents it to the T cell. The T cell is actually the one that attacks the tumor. Now, having said all that, of those 3 mechanisms, by far the strongest one is simply anatomically increasing the blood flow, getting the agents there. I wish we had a more robust immune reaction. And I think in the future, now that we have immunotherapies, we're going to be doing some research. That's really not ready for prime time at the moment. But the hope is that stimulating that immune response can work with other immune stimulatory agents that prevent that tumor from hiding from the immune system, as it so often does. But meanwhile, we've got the other very, very valid, well proven in studies, mechanisms to lead to improved responses to the underlying chemo or radiation therapy. So again, we make those therapies work better. If those therapies don't work, that's a problem. But they usually do work to some degree. We can make them work better.
Right. And so, you do see this really simple kind of underlying core of you're just bringing more of what's in your blood into that tumor, right? So if you're having systemic chemotherapy, that's in your blood, it's affecting your healthy cells in a negative way, might as well optimize the usage of that and focus it in a tumor.
Absolutely, you're spot on. And I'll also add, unlike radiation therapy, which really has to be precise, I mean, it's high energy. Okay, we do have some direct killing by heating those cancer cells, but it pales in comparison to chemotherapy or radiation therapy. I mean, those therapies are, we call them the parent therapies. They should get most of the lion's share of the credit. We're okay with that. We just make them work better. But when you actually apply the heat, it's amazing that you can just go to that level, because at that level of temperature, 106 to 109, 41 to 43 degrees Celsius, you do not have any adverse effects on normal tissue. And we've treated almost every tissue in the body.
Yeah, I think that's an encouraging thing for people to hold to. It was encouraging for us, recognizing cancer may feel, and there's truth to it, may feel extra aggressive and really hard to get rid of. But when you really look at it and you go, a cancer cell is less robust and less stable, and has fewer survival mechanisms than a healthy cell in a lot of different environments, whether you're talking oxidation or heat or even response to chemotherapy. A cancer cell's ability to bounce back is reduced because of the mutation. And so then it totally changes how you think about it, where you say, okay, all I'm trying to do is stress, because a cancer cell can't respond to stress in the same way. It doesn't have the same like elasticity in survival as my healthy cells. And so, yeah, I'm going to heat this area. In Rachel's case, we were heating the liver. I'm going to heat the liver, and her liver is going to be just fine. But it's not going to be just fine are those cancer cells and those tumors.
That's exactly right. And that's why we have multiple individual cells, which I'll get into when we talk about the device. Yeah. And we essentially overtreat, right? We treat the tumor and the surrounding tissue, which is a potential advantage. I mean, there's no reason for us to not do that. So again, it's in contrast to something like radiation, where you're off by a millimeter, depending on the area of the body that you're talking about. You might be causing some real
significant impact.
Yeah, we don't really have that issue. Not that there are no potential adverse effects. We don't heat enough to get a third-degree burn. I mean, you could get blisters. They're very, very rare in our hands. Some people get some pain. Some people get some nausea. It's unusual. It happens from time to time. We talk openly about it. I have visits with people during their, treatment, so that we could, if anything does happen, we could address it.
Yeah, that makes sense. And so, if the primary mechanism is just the simple fact of you're getting blood into the tumor more effectively, the next one being heat and the effect that heat and the temperatures that you're targeting has on a cancer cell. I guess next, what would be maybe helpful, or what I'm curious about, is more about the devices used themselves. So maybe could you paint a picture of what the world of hyperthermia looks like? And maybe we'll focus on localized, because I know there are some major differences. Localized hyperthermia in the industry, and then what you use and why.
Sure. So I'm very, very glad that you framed the question the way you did, because that clarifies for the audience that in the United States, where we have an FDA, there are only two modalities that are approved, and they are both localized therapies, as opposed to, and I'm going to bring this term up just because if you search hyperthermia, you probably will come across it. Better we confront it head on, of this whole body hyperthermia. I put it in quotation marks. Why? I'm not dismissing it. I don't understand the technology. I'm not an expert in that area. I will tell you this. It is not compatible with life to heat your entire body to 109 degrees. I've had patients come in and tell me they've gone to other countries. They've hallucinated. I don't know what they're doing to them. But we've
heard some stories.
Again, I don't understand that, and it's not rigorously evaluated in this country. So, but we're here. We're in this country. You don't have to go to another country, because we have stuff that we have studies that are being done on. So the type we use is ultrasound based. And the other type is microwave based. Both are FDA approved therapies. Microwaves, it's a bit more difficult for them to get deeper into the tumor traditionally. That therapy has come a long way. It's used in certain institutions. We chose a different route. Ultrasound tends to be very, very, very well tolerated. And again, because I don't do microwave hyperthermia, it is FDA approved. But my understanding from somewhat apples and oranges comparison is I certainly would stand by the ultrasound-based hyperthermia that we use. So what happens is we have a device and it plugs into a 220 outlet, and it is a machine that is not dissimilar to diagnostic ultrasound. So that's the other thing that people like, because all that's different is the wavelength of the ultrasound waves.
Right.
And so what happens is, rather than bounce off and then be captured and you get a sort of an image, as you might in pregnancy or in evaluating the abdomen with an ultrasound, the ultrasound frequencies that we use in our devices penetrate. And they can penetrate up to 10 centimeters, not including the thickness, your natural layer of fat, because it goes through fat really quickly. And then gets absorbed through muscle, and bone is the biggest heat sink, but that's usually not an issue unless you have a bone metastasis, in which case we can treat that. But most of the things we treat are solid tumors. We're approved for all solid tumors, as I think I had mentioned. Typically the most common ones we treat are livers, are probably one of the most common organs because many different tumors metastasize to the liver, treating breast cancer, head and neck cancer, rectal cancer, colon cancer. The list goes on and on and on. For our therapy, the only thing that is a limitation is that, similar to diagnostic ultrasound, when ultrasound waves of any frequency hit air, they just stop. So you've never heard of anybody getting an ultrasound of their lung. So the reverse way to think about that is, anywhere you can get an ultrasound, we can treat. We can treat your arms, your head, your neck. Yeah. The only other caveat is, again, you don't really get an ultrasound of the brain. Why? Because it bounces off the skull. In our situation, bone absorbs heat the most of any tissue. But if you did have a skull metastasis, we could treat it. We treat spinal metastases all the time. So it's not that we
Interesting. Yeah.
We just can't get through it to
the next.
Yes. But in any other tumor type, and you can't miss us on the internet, but we're hcioncology.com. We go over, many of the tumors. We can't even list them all, but many of the tumors, particularly the ones where there's robust data.
Got it. Okay. So what have you found from a success rate standpoint? And maybe let's just narrow that down, because I know it is hard to go super broad, but narrow it down to, in conjunction with chemotherapy and or radiation.
Yes.
The success rate difference between applying hyperthermia or not.
So let me give you the data as it stands. And the reason I'm doing that is not because then what I'm going to do is I'm going to contrast that with some cherry-picked, and I say it that way because that's what they are, really good outcomes. Okay. And I'm going to explain why I'm doing that, because we're not right now. This was a therapy that was FDA approved in 1987. It kind of didn't find its niche, which is why, as a freestanding center, my understanding is we are by far the largest treater by volume and number of treatments anywhere in the country. I don't know about the world, but certainly we're doing quite a bit. And because we rely on the science. And then what the science says is, if you look, for example, at hyperthermia combined with radiation therapy and head and neck cancer, radiation therapy alone, which is typically now used with chemotherapy. So these are older studies, mind you.
Sure.
But complete response rate of the treated area went from 41%, and complete response rate means you can't detect the tumor anymore. Doesn't mean you're cured necessarily, although these days a very high percentage of patients with, head and neck cancers, unless they've been let go for years and years and years, very high percentage tend to be curable, mind you.
Right.
But in the older studies, if you looked at radiation, 41% had a complete response rate with radiation versus 83% with radiation hyperthermia. So that gives you
literally double.
Yeah, correct.
That's incredible. I mean, that goes from a flip of a coin to roll a dice and don't hit a 6 and I'm fine. That changes the odds significantly. Well
said. You are a polymath. And then looking at breast cancer, same types of studies. And I say it that way because, again, many of them were done in the 80s, 90s. And we recognize, now that cuts both ways because many of them had smaller numbers of patients. But if you can show differences with smaller numbers of patients, then you're really good. And almost all of them align. Not all of them. Sure, there are some studies out there that are not showing these, but the majority of studies show results similar to what I'm sharing with you, and they're all on our website and the actual sources there. You can look it up for yourself. But with breast cancer, 41% with radiation alone. Actually, this happens to be the same as with head and neck in this particular study, versus 59% with radiation plus hyperthermia. And then
still a more significant,
That's right. Yeah. And remember, the older studies, again, everything cuts both ways, as I've been saying. So now bring this into the future where you have more effective therapies now. And granted, we're not redoing studies with every therapy. I mean, get new therapy every week. I mean, it's just not doable. But the point is that the principle, the machine's going to do what the machine's going to do, which is to bring the agent directly there or to help the radiation work better, whether it's given alone or in some tumors with chemotherapy. And then the final one I'll bring up is rectal cancer. And rectal cancer is a specific type of cancer. And the reason why it is separate, one of the reasons why it's looked at separate from colon cancer is because the tissue is a bit different, but also the location is a bit different. And so you can use radiation therapy. So surgery alone, 41%. That number keeps coming up. It's very interesting. I don't. It's just a coincidence, actually.
Yeah.
Radiation plus surgery, and these are again somewhat older studies, or early 90s, mid 90s. Radiation plus surgery, 50%. This is overall survival at 5 years. So from surgery alone at 41%, radiation plus surgery goes to 50%. Remember, it's much better now. Okay, but this is the older studies. Radiation plus therapy, radiation therapy plus surgery plus hyperthermia, 67%. Now you're talking about overall survival.
Yeah.
Overall survival at 5 years. 41% surgery alone, 50% radiation plus surgery, 67%. Those are not trivial numbers when we're talking about being alive.
Yeah, I mean, that can flip the script for someone.
Yes. Now let me talk about two situations. So a lot of people will ask us, they'll sit across from me and they'll say, well, how do you know you work? And I'll say, very much like taking, you go to your oncologist and let's presume that chemotherapy is the appropriate therapy for your particular type of tumor. You don't know, you're not in a study. This is standard of care. You don't know until you get your next scan how well that worked. And it's not dissimilar with us. So how do you tell? Well, you get the scan, and it's the same for us. But I'll share with you ones where it's difficult to assume that we didn't work, because we had one older lady. She had vaginal cancer, and vaginal cancer is treated by radiation therapy. And there's a couple ways you can give radiation therapy. One is external beam, and the other one is to implant the seeds, called brachytherapy, right? Okay. So we worked in conjunction with a radiation oncologist who we work very, very closely with. And it turned out that the particular vaginal cancer she had was invasive. Just after the photons alone, so the regular radiation therapy that would just shoot a beam at you, gone. And that particular radiation therapist never saw that in her entire career. So again, that's, when we get reactions like that, it's very, very, it's encouraging that we probably played a role. You never are 100% in medicine. The other one is we had a lady with stage 4 breast cancer. And this one, some people by happenstance are almost their own experiment. So she had something called HER2 positive. HER2, people may have heard of that. Your audience may have heard of it. They're pretty savvy in cancer. But, it's one of those ones where there are targeted therapies against HER2. It's a particular receptor on the breast cancer cells. And there are about 4 different therapies. She's tried actually 3 of those before, and there was a response, but then they stopped working. Okay. She was referred by a radiation oncologist. She didn't want to get radiation to the chest wall because she wanted to have reconstruction of her breast. So she decided to utilize a 4th type of anti-HER2 therapy called Enhertu. Okay. When we did it with hyperthermia, she had open wounds on her chest wall, completely cleared them over between July of last year and October of last year.
Wow.
She then had a liver lesion, and that liver lesion shrunk a bit. And so we hadn't treated that yet, and it shrunk a bit. So again, the parent therapy was working. That's the whole point.
Yep.
I wanted to. It's not all hyperthermia.
Yep.
When we applied hyperthermia to the liver, gone. The final place, and this was really the part that I think completely convinced her, and not that she was doubting it, but it was like, oh my gosh, was the spine. So she had lesions in her spine. As soon as we went over to the spine, it was gone. And those did not change in that October scan. But by February of this year, she had literally no evidence of disease. None.
Wow.
And her tumor markers went down to normal. So
to normal level.
Yeah. So again, do we know how much we contributed to that?
Sure.
But nothing, but from stage 4 to no evidence of disease. I mean, we've never done that before.
It might not be a measurable response, but there is a binary. Did it help? Yes, no.
Yes. It's hard to say no, particularly given the sequence of how we attacked each of the sites.
And so again, what response was happening.
Because, I'm very open with patients. I said, that's not a study, but it is something that happened.
Yeah. And I think what is always encouraging when hearing stories like this is people often feel like they get to the end of their path. Like I am out of options. And depending on the doctor that they're working with, they may kind of get told that of like, your tumor isn't responding to standard of care treatment. And so when you add like, hey, there's potential here for changing that. Like, okay, it's not responding to the treatment that we have available to us, but there are things that could have an effect on that and change that narrative and allow for response to happen, that brings hope. And I think that's maybe the biggest thing I want to make sure that we share with people who are listening to this is we hear all the time. And I was just talking with you about someone we were in contact with that I think is working with you now. That we hear this like, hey, we've been told we can't get a response. And so they're kind of saying we're out of options. And all you have to do is go, well, what about hyperthermia? And all of a sudden that's a new path that could, and looking at the statistics, it often does improve response.
Very, very, very accurate. And it's important to recognize the continuum of a response and the continuum of what are options for patients and where they are in the disease process. So let me operationalize what you just said. So it's not uncommon for us to have patients with very early stage disease come in. That's great. Curative intent. We help with that. We can help with that. Mm-hmm. Then there's the patients with stage 4 disease, and we may have different goals. I never, ever say someone can't be cured. That's just not my place, okay? Having said that, I think it's very difficult. You wouldn't necessarily expect a cure in stage 4 disease, and that's really the oncologist's call. I just do the hyperthermia portion of it.
Right.
But to your point, there are people that respond amazingly well. There are people that don't respond at all. And there are people where there's a bit of a response, but could you push it over? And the answer is maybe.
Yeah.
and and again, the same way I'm talking to your viewers, patient sitting across from me where I'm sitting right now is where I typically do my patient histories. Same response. And again, I try not to overpromise things because, you don't know, but the data supports it, and it does provide hope. One of the interesting things is so few doctors know about this. And I've noticed in the past 4 years since I was medical director and now chief medical officer here, that the responses of local doctors went from, on occasion, which is to me a little bit odd of a reaction to an FDA approved therapy, but don't do that.
Right.
Occasionally doctors would say that. It would be like, I don't understand that. I'm happy to talk to them. They clearly don't know the data, but okay, that's their opinion. But people got familiar with it. And so we're very slowly. And so now all of a sudden we have a number of patients where when we have those outsized responses, you could see the light bulb go off. And now all of a sudden, one by one, locally, we get people from all over the country, but one by one locally, the person's like, I really think you should keep doing that. It's kind of comical in a sense because of the
and tragic
action, but that's the way it goes,
Sure.
And so,
I think we find that in a lot of different areas, and so we've been in the cancer world for 4 years now, and talking with doctors, and we met up at the Metabolic Health Summit. I think that's kind of a good example of you have this body of the medical community that is leading edge in so many areas and ways, that save lives and are improving outcomes, and they can sometimes be the trailing edge in other ways, and the last to get on board with certain things. Maybe nutrition as it relates to cancer is one area that it does feel like the medical community is on the trailing edge, but catching up. And there's a lot of other ways that has been the case as we've kind of interacted and gone, okay, we need and see the value in the body of knowledge that the medical community brings, the traditional Western medical community. And we, for our own outcomes, for Rachel's outcomes, want to add to that people who are on the leading edge of these other areas. And that becomes a really powerful combination.
I fully agree with you. And I think, it's interesting because although I'm fully Western trained, I'm an MD, I've done molecular research at an academic institution.
Mm-hmm.
You can read my bio on the site. I've worked in biotech, but we are beloved by both folks who are pursuing full-on Western therapy and folks that are pursuing full-on natural therapy and everything in between. And I think one of the reasons why is because, we have that FDA approval, which and most insurance companies will reimburse for this therapy. So it is 100% not only legitimate, particularly people who often use complementary therapy. All those complementary therapies are out of pocket. Okay.
Mm-hmm.
Most of the other standard therapies are covered. We just happen to use a natural force, heat. We do it in a sophisticated way, but we're the best of both worlds. We're Western.
Yeah, absolutely.
But we're natural. Okay.
Yeah, you fit in the standard of care optional category, right? Where it's absolutely, according to the FDA and everybody else, it's part of standard of care, just not widely accepted as
correct
as a part of the standard.
Right. Yeah. And it goes back to, I just would never have a person not look into this who has a solid tumor. There's no reason for them to not look into it. Just go to the website, call us. We'll have a very open conversation. We work for the vast majority of patients to some degree, the same way that other therapies do. I'm not making any claims that, I don't think are supported by the data, by the literature and data. But sometimes we hit a home run and sometimes we can't help. I mean, it spans the spectrum.
Yep.
I'm very honest because that's just the way you should be.
Yep.
But
and nobody can make promises, right?
Yeah.
In a complex world of cancer,
Yeah,
can't make promises.
There can't be any promises. It's just not part of the equation.
Yeah, but there can be hope, and I think that's
But
the
there
important
should be
bit.
hope. There absolutely should be hope. And
Yeah,
agreed.
absolutely. Well, Dr. Pinzone, thank you so much for spending this time and talking through the science of heat and hyperthermia as it relates to cancer. In the coming weeks, we're going to have more conversation about your facility specifically, and some of the interesting things that you guys are doing there. And then I also want to pick your brain on your advice as a doctor, as an expert in this field. Kind of if you got diagnosed, Lord forbid, if you got diagnosed tomorrow, what would you be doing? And so we'll dive into that in the future.
Excellent. Thank you so much.
Thank you.